We'll be talking about the heart and the heart anatomy coming up. So when we have the heart is essentially the central component to the cardiovascular system. And without the heart, the blood does not flow through the rest of the system itself, and so it's needed in order to do that. And essentially, it's the go-between between the arterial side and the venous side of the circulation itself. And so when we look at the heart and all of its circulation that we have there, we have arteries, which are always taking blood away from the heart, and then we have veins that are always taking blood back to the heart. The only place where this is, in a sense, not true as far as the blood that is in them, as far as the high oxygen versus low oxygen content, is when we go into the pulmonary circulation. So arteries typically have high oxygen content, veins have low oxygen content, but because the arteries and veins are always by definition either coming or going from the heart, when the arteries are going from the heart into the pulmonary circulation, they are bringing low oxygen to the lungs, and then the veins coming back from the lungs to the heart are bringing back high oxygen content blood. And so, even though they are veins, they are going to have a high oxygen content. When we look at the heart itself, because it does provide for circulation in essentially two different spaces, we have a pulmonary circuit and then we have a systemic circuit for the body. That means that we have effectively two pumps. And so we have a left-sided pump and we have a right-sided pump, both bringing the blood within them to different areas of the body itself. And so the right side is getting our blood out to the lungs. And so we're going to do our gas exchange in the lungs themselves. And then the blood in the systemic circuit is going to bring blood to the rest of the body tissues themselves. Since we have two pumps, we need some valves to make sure that the blood is always constantly flowing in the same direction. And so we're going to see valves inside the heart. That's there. And the whole idea of the heart is that we generate pressure with each contraction, and that contraction is going, and the pressure that's there is going to drive the blood flow through the entire system itself. So our two systems or our circuits, we have our pulmonary circuit and we have our systemic circuit. The pulmonary circuit goes from the right atrium into the right ventricle, out through the pulmonary trunk, through the pulmonary arteries, and into the lungs. And there it's going to drop off CO2. And so carbon dioxide rich blood is going to go into the lungs and it's going to pick up oxygen. And so it's going to get oxygen that it's going to then return back towards the heart itself. The systemic circuit then involves the left atrium and then the left ventricle. As blood then goes out into the aorta, it's then traveling along the systemic circuit. And so this is now oxygen-rich blood. This is potentially nutrient-rich blood that's now going to go out to the tissues, drop off the oxygen, pick up more carbon dioxide, drop off nutrients, pick up waste, and then once again bring it back towards the right side of the heart. So here we can see kind of a simplified version of what we have going on for that process itself. And so blood comes back from circulation into the right side of the heart, coming into the right atrium, and then it goes into the left atrium, and then out through the pulmonary trunk and into the pulmonary arteries. Goes out to the two lungs, comes back in via four pulmonary veins, two on either side, and then now we're back into the left atrium. Blood then goes into the left ventricle, comes out the aorta, and then goes out through the rest of the systemic circuit itself, gets out to the tissues, does its gas exchange and nutrient exchange there. When we look at the actual muscles, so when we looked at tissues themselves, we talked a little bit about the differences between cardiac muscle and smooth muscle and skeletal muscle. And so here the same applies as far as the microscopic view of the actual cardiac muscle tissue itself. And so when we have cardiac muscles, those individual cells are relatively short, they branch a lot, they have special connections between them called intercalated discs. Since the heart muscle has to basically work 24 hours a day, 7 days a week, 365 days a year, it's constantly contracting. it needs to have a constant energy supply. So it has a lot of mitochondria within the cells themselves. This is going to supply all the ATP that those cells need in order for contraction to occur within them. Those intercalated discs have gap junctions in them, remember, and those gap junctions are going to allow us to move content in terms of ions and thus the electrical potential from one cell to the next. And so this essentially allows for the cells to start to contract as one big unit within the heart itself. The heart, when we go to look for it, is going to be found within the thoracic cavity. And so it's roughly the size of a normal heart is roughly the size of a person's clenched fist. It's going to be slightly off towards the left from midline. So it's going to appear more so on the left side of the chest than it does on the right side. Oftentimes the right side just kind of barely peeks out from behind the sternum on the right hand side versus the left hand side goes all the way towards the middle of the clavicle. And so it's essentially out here along that midclavicular line area over on the left hand side. The apex of the heart actually points downward. And so the apex of the heart is here, the base of the heart being up here. And so it's not just pointed straight up and down either, but it's actually tilted a little bit over towards that left-hand side as well. Here we can see it on an X-ray. And so we see, once again, kind of the outline of the heart here as it sits inside the chest itself. And then the great vessels are going to come off of the base there. This is a peculiar X-ray in that in this one we have a variation that is something that happens sometimes in development. And so if you look at the shadow of the heart, it's actually over here. And so it's essentially on the right side of the chest. This is a situation where the organs, and so in this particular case, this is what's referred to as situs inversus. And so this is where all of the organs have rotated to the wrong side, essentially. So everything is on the wrong side. We can actually see a stomach bubble over here as well. So we know that the stomach is on the wrong side of the body also. Versus dextrocardia, where the heart here is again on the wrong side. But the gas bubble over here in the side of the stomach is an indicator that the rest of the organs are all in normal position. And so with dextrocardia, we have just the heart being rotated to the wrong side, which is a little bit more problematic because that means that the lungs are on the correct sides and the lungs themselves are now going to be compromised in that way. The left lung is normally the one to make room, in a sense, for the heart, and now the right lung is having to do so there. So if we were to look at a specimen of the heart itself, we'd be able to see a few different things from just the outside of the heart, and so the external anatomy that's there. And so we're going to see things like the atria, and so we have the right atrium over here. We have part of the left atrium. The majority of the left atrium is actually a posterior structure. We can see the right ventricle. We can see the left ventricle. And in between the two, we then have the interventricular sulcus. And so there's a bit of a groove there in between where the two ventricles are. And so this is where our blood vessels are going to run as well, in that little interventricular sulcus there. So there's a little bit of a depression that's there. And there's also a posterior one. So we can see it on the posterior side as well. And so here we have our interventricular septum on the posterior side. Here now we can see that the left atrium is primarily a posterior structure. And it also gives us a good view of the pulmonary veins. 1, 2, 3, 4 there on that side as well. The aorta comes off of the left side, and so it's going to come up and out, and it's actually going to turn and start to go back down. And so it becomes the descending or thoracic aorta. making its way down into the abdomen that's there. Both of the atria have an extra little kind of flap-like extension, which is the auricles, and the auricles allow for kind of a little bit of an extra expansion of the atria themselves, and so we get a little bit extra blood inside of them. Inside the heart, we now have the right atrium over here, the right ventricle, the left atrium, and then the left ventricle as we look at it inside there. We can see these big white valves that are here. And so we have some nice valves inside the heart. And so going between the atrium and the ventricle, we have the AV valve here, so the right atrioventricular valve. Sometimes that valve is also then referred to as the tricuspid valve. Goes by some different names. We have the bicuspid or mitral valve over here. And then we have two valves on our big vessels that are leaving the heart. We have the pulmonary valve, and then we have the aortic valve as well. So the right atrium is getting blood from systemic circulation. So it's coming into the right atrium from the rest of the body itself. And it's getting its blood from the superior and inferior vena cava. Superior vena cava basically draining everything from the head, the neck, and the upper limbs on there. And then coming from the torso. And then the inferior vena cava coming from the lower part of the abdomen and then all of the legs. And so bringing blood in through there. In addition to the two vena cava, the right atrium also receives blood back from the heart itself via the coronary sinus. And so this is going to be returning blood from the heart's own circulation. In between the two atria, we have a septum as well. And so there's a wall that divides the two in there. In the right atrium, it's relatively easy to find what's referred to as the fossa ovalis. And so this is a little impression or depression that occurs within the wall of the atrium itself. This used to be opened up and it used to be a foramen that allowed for blood to flow from the right atrium to the left atrium during the fetal stage. From the right atrium, we go through the right AV valve or the tricuspid valve. And so that tricuspid valve has three flaps on it, hence the name tricuspid. Those three flaps have attached to them little tiny ligaments, and then those little tiny ligaments are attached to muscles. The muscles are the papillary muscles. And then attaching into those valves, we have what amounts to something that looks like little strings inside there. And so those little strings attach to the papillary muscles and then allow for that connection between the two to help to close that valve nice and tight. When the ventricle contracts, the ventricle is going to generate a lot of pressure inside there, and that pressure is going to want to go to an area where there's low pressure. Well, the atrium is relatively low pressure, almost zero. And so if we've got high pressure in the ventricle and low pressure in the atrium, the blood's going to want to go to the atrium. And so this is where the papillary muscles pull on the tendons and then pull on the valve, and that keeps it nice and closed shut. The blood is then only able to go out of the right ventricle and into the pulmonary trunk through the pulmonary valve. So that right ventricle itself has blood that's coming from circulation. So it's deoxygenated blood. Inside the ventricle, we have, in addition to the papillary muscles kind of look like little fingers sticking up. The chordae tendineae are the actual tendons that connect between our papillary muscle and the valves. So this is the little strings that are going to pull on the valves and help to hold them shut. All the rest of kind of the bumpy space that's inside the ventricle is what's referred to as trabeculae carneae. And so this is the the rest of the motor component that is in the walls of the ventricle itself. The right atrium, if you have a good specimen, you may be able to find a moderator band as well. And so a tissue connection between the two sides of the ventricle. From the right ventricle, we go into the pulmonary trunk. Pulmonary trunk is going to get us out to the lungs. In order to go into the pulmonary trunk, we have to go through the pulmonary valve. And so the pulmonary valve, or the pulmonary semilunar valve, is a valve that does not have any kind of extra attachments to it. And so just the three little cusps are enough to hold back the blood up in the pulmonary trunk. And so since the pulmonary trunk, the aorta, is only momentarily having to receive a large, high pressure volume, and then the volume and the pressure starts to go down and down and down and down relatively quickly after that, it doesn't need to be reinforced like that of the AV valves. So it doesn't have those extra connections on them. From the lungs, we come back via the pulmonary veins. The pulmonary veins get us into the left atrium. The left atrium is then going to contract, push the blood down into the left ventricle, going through the left AV valve, the bicuspid, or the mitral valve. This one goes by 3 separate names, depending upon who you're reading at the time. This one, as the bicuspid part implies, it only has 2 flaps. So it only has 2 flaps to it. It still has chordae tendineae, and it still has papillary muscles attached to it. So we're still going to keep that valve nice and tightly closed during contraction, but there are only 2 flaps on the valve itself. That's there. Those valves can sometimes go bad, and somebody may need a replacement valve inserted. And so here we have an example of a replacement valve that's there inside. And this is what we can't see here is that there would be a little ball inside this little cage. And so that little ball inside the cage there is what would actually serve as the valve itself. The other thing that we can see here is that during open heart surgery, requires the opening up of the chest, and so the sternum has to be cut in half. And then when surgery is all done, they then use metal ligatures to sew it back together, and so to basically hold that sternum back in place. A alternative to the potential for a valve replacement is what's called the MitraClip. And so the MitraClip is kind of like a paper clip. And so it essentially helps to hold the valve together, helps to hold it closed. It can be done, and it's inserted via a catheter. And so similar to going into if somebody needs to go into the cath lab to have their vasculature of the heart evaluated, the same process basically is used to introduce a MitraClip. And so here we can see on an x-ray we have MitraClips inside the valve. And then in addition to that, the person also has a pacemaker. And so this one has more than one thing going on within their chest itself. From that left atrium, we get into the left ventricle. This is going to be our high pressure ventricle. So this is the high pressure area of the heart. And you can see that the wall of the heart is a lot thicker on the left side than that of the right side. And so a large amount of more muscle mass there in the left side compared to the right side. And it makes sense because the left side of the heart has to pump to the entire body. The right side of the heart only has to pump out to the lungs. So we've got a lot less resistance on the right side compared to the left side. So the muscles can be a bit smaller on there. When we look at all of the trabeculae carnae inside there, we have a lot of rough groove surfaces inside there. We're going to see our papillary muscles. We'll see the chordae tendineae attached to those papillary muscles as well. From the left ventricle, we go out to the aorta. And so now the blood is moving into the aorta. As it moves to the aorta, it's going to pass through the aortic semilunar valve. And so this valve now once again has three cusps. So there are three portions to it. There's nothing special attached to it. So there's no chordae tendineae, there's no papillary muscles attached to these ones either. And this one just blocks backflow of blood coming from the aorta back into the right ventricle. And so we don't want to have any kind of a regurgitation of blood as it comes back through. The aorta, as it comes off of the heart, it makes an immediate curve in it. And it also gives off three big branches right away. These are going to go to basically the head and neck. And so we have our brachiocephalic trunk. We have our left common carotid. And then we have our left subclavian. And so those three branches come off right away on the heart itself. And we can see them here as well. Brachiocephalic trunk, left common carotid, left subclavian. And then those are going to go up, and the subclavian is going to come off like this and go down to the arm. Common carotid is going to go up and go up to the head. And then brachiocephalic trunk is going to come off, and it's going to give off a similar common carotid and subclavian as it makes its way along the clavicle as well. When we look at the heart, it's also sitting inside a little sac called the pericardial sac that's there. So we have pericardium that surrounds it. That heart is then has three layers to the heart wall itself. And so it's not just all muscle. We have an epicardium, we have a myocardium, and we have an endocardium working our way from the outside in. So when we look at the heart itself, here we can see that pericardium that sits on the outside of the heart. That pericardium is basically like a double-walled sac itself. And so we have a portion that is essentially makes up the sac wall over here, and that's the actual pericardium itself. That's there. And then, oops. And then from there, we also have components of the heart wall. And so on the very outside of the heart wall, we have our pericardium. And so that serous pericardium is there on the outside. This is the visceral layer of epicardium. And then we have the parietal layer of pericardium out here. In between the two, tiny bit of fluid, and that little bit of fluid is going to reduce friction as we have it there. The middle layer then is the myocardium, and then all of the inside lining of the heart is the endocardium on the inside. So here we have the myocardium. So myocardium is the actual muscle wall itself. And so all of this area in here is all of the myocardium that's there. From there, the endocardium sits on the inside. So this is like the lining of the inside of the heart itself. So this is everything that we would see on the inside that's there, surrounding the inside chambers themselves that are on the surface itself there also. Then we have a little tiny bit of the visceral pericardium sitting on the outside of the heart wall here as well in this particular part. The heart, as it contracts, is designed to make it so that both sets of chambers contract at the same time. So we have both sides of the atrium contract and then both sides of the ventricles contract. But the contraction itself is off in terms of the atrium and the ventricles. So the atrium contract and then the ventricles contract. And then we go back to the atria and then back to the ventricles. And so they're not actually contracting at the exact same time between the ventricle and the atrium that are there. So they're always going to be contracting and relaxing. When they are contracting, we have what's called systole. And so systole is that contraction. And then diastole is the relaxation of the chambers themselves. So during systole, we're having blood ejected from the heart. During diastole, we're having blood filling the heart. And here we have kind of a chart that uh, divides everything up in terms of what's happening at every moment within the heart itself. And so during both atria and ventricles have a systole and a diastole within them, and different things are happening during each time. So initially the atria contract, and so we have atrial systole. That's going to allow for the ventricles to start to fill, and then the ventricles are going to start to contract. But if you look at the valves that are there for that contraction, you'll see that the valves themselves are actually still closed. All four valves are closed. This is allowing for pressure to build inside the heart. And so that's going to build and build and build that pressure. Eventually, the ventricles contract so much that the pressure inside the aorta is overcome, and that pressure is then going to come and move out through the aorta and into the rest of the body from there. And so we're going to have a high pressure area at that point. Once ventricles are done contracting, we then go into diastole, and we're going to have a period of time where, once again, we have what we call isovolumetric relaxation. So we had an isovolumetric contraction to build the pressure. Now we have an isovolumetric relaxation where the ventricles aren't filling because the valves are not open yet. In order for the heart to contract how it does, it needs a good electrical system inside. And so it has a nice conduction system that's there. The heart cells themselves are said to be autorhythmic. So they set their own pace. They set their own rhythm as far as when to contract at any given time. So special muscle fibers are found within the actual muscle cells themselves, and those special muscle fibers allow for contraction to occur. And so these are essentially non-contractile fibers, and they're going to generate the actual impulse that spreads across the heart for contraction to occur. So this allows for that transmission of the electrical impulse all throughout the entire heart, because we're going to go from the SA node to the AV node to the left ventricle, and then the ventricles are then going to contract and eject the blood from the heart itself. So as we look at that process here, we have the SA node generating an action potential inside the right atrium. That then sends its signal across to the left atrium over to the AV node. We come down the bundle of His, a right and a left bundle branch, comes around a corner and comes back up through the Purkinje fibers. And then we have our electrical conduction through there. We can mirror that contraction with looking at an EKG. So the EKG can show us those contractions and how they're occurring at the same time as the electrical activity is being monitored with an EKG. So we start out with the SA node firing. That SA node, all the green there, travels across the atrium, across to the other side. That stimulates the AV node. The AV node then sends the signal down through the bundle branches, so our bundle of His, and then it gets down to the bottom and it comes back up Purkinje fibers from the bundle of His, and then we get ventricular contraction. If anything disrupts that electrical pathway, then we're going to have a problem in the heart. And so this is going to disrupt that normal electrical activity. We'll see that on an EKG, and eventually the heart may even stop once it's there. The innervation that the heart does have is both sympathetic and parasympathetic. So it does have both a sympathetic side and a parasympathetic side. Those two sides lead us to kind of different information. So sympathetics are going to do things like increase heart rate, increase contractility of the heart, versus the parasympathetics are going to do just the opposite. So they're going to decrease the heart rate, they're going to decrease the contractions and allow for the heart to, in a sense, rest. The majority of the time, luckily, we're in a parasympathetic state. And so we're in this state where things are just kind of going along, things are all good, and we don't have to be in an alarm state whatsoever. The heart does have its own blood supply as well. So we have our coronary circulation. And in all reality, the heart takes first dibs. And so it takes the first blood from the aorta. And so we're going to have a right and a left coronary artery. Those coronary arteries are then going to supply the entire heart itself that are there. And so they're the only branches of the ascending aorta. And this is going to get immediate blood supply out to the heart walls. So arterial flow goes out through the left and right coronary arteries. The left coronary artery is going to actually kind of be tucked up underneath the pulmonary trunk, and then it's going to pop out kind of at the base of the heart there. And then from there, it's going to split, and it's going to split into a circumflex artery and a left anterior descending, or an LAD. This is also sometimes referred to as the anterior interventricular artery as well. And so it goes by a couple of different names there. So the anterior interventricular comes down the anterior interventricular sulcus. The circumflex goes across to the left side and travels along to get towards the back of the heart, and then it drops down as the posterior interventricular artery. And so it's going to join the posterior interventricular artery on the posterior side. The venous return then comes back through the veins, and instead of calling them coronary, we now call them cardiac. And so we have a great cardiac, a middle cardiac, and a small cardiac vein, which are kind of the larger veins that all drain into the coronary sinus. The right coronary artery pretty much stays the right coronary artery, but it does give off some branches along the way. One of the major ones is the marginal artery, and then it continues along to the posterior side, joins the posterior interventricular on the back side. So here we can see that circulation as it occurs within the heart itself. And so we have our left coronary artery. It came out from underneath the pulmonary trunk, and then it immediately split into a circumflex and an anterior interventricular. The right coronary artery came off, and it follows along the right atrium, gets around to the backside, and then is going to go do the rest of its thing at the heart. For return of blood, we then have the great cardiac vein. We have the small cardiac vein. So the great cardiac vein basically drains the anterior part of the heart, the left ventricle, and then it goes into the coronary sinus on the posterior side. The small cardiac vein comes around from the right side and wraps itself around to drain into the coronary sinus as well. And then the middle cardiac vein comes up the posterior interventricular sulcus there. And so it's coming up along the same spot as the anterior side had for blood moving along the anterior side of the heart in that anterior interventricular sulcus. Those blood vessels, you've heard of them becoming occluded, and so somebody has a heart attack, something like that, or maybe they're having chest pains, they go to the cath lab, and in the cath lab they run some tests to see where in the blood vessels there is a blockage, and if they find that blockage, then they'll put in a stent. And so this is what a stent looks like. It's basically like a little cage, and it gets inflated, and it increases the size of the blood vessel. Doesn't really fix the problem per se, but it at least opens up the vessel. And here we can see it on an echocardiogram where beforehand we had stenosis of that blood vessel. And in the after picture, there's no blockage there. There's no decreasing in flow into the area itself. Next up, we'll talk about the blood vessels.